The doctor told me that, look, you have hepatitis B, so you cannot go overseas. No one at all from my village had that opportunity to go overseas for study. And for sure, my parents would not be able to afford any of that. So having a scholarship to study overseas is actually a really big deal for someone from a village in the north of Vietnam. And I was lucky enough to secure a scholarship to study in Europe. And as a part of the paperwork, I have to go through a health check, and hepatitis B test is among the health check. So when I came to get the result, the doctor told me that, look, you have hepatitis B, so you cannot go overseas. And then I had to reject the scholarship just because he told me so. I don't know why, by that time I didn't challenge him or explore more, whether what he said was correct. But look, as a first year university student and you had no experience in life, and then you tend to trust everyone that deemed to be more superior than you, like the doctor in the hospital.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
Hoy es un día muy esperado para todos los integrantes de la Asociación Buena Vida, porque celebramos la cura de varios pacientes de hepatitis C. Nosotros en nuestro grupo decimos que vivir con el virus de hepatitis C es sentir que uno tiene una bomba de tiempo dentro de uno y que no sabe cuándo va a explotar. La cura significa desactivar esa bomba. Por eso estamos todos juntos hoy para festejarlo, entregar las remeras con la inscripción de hepatitis C curado, y ese es el momento cúlmine de nuestra labor como voluntarios de la Asociación Buena Vida.
Soy Raúl y estoy curado.
Soy Majo, estoy curada.
Soy González Julio y estoy curado.
Hola, soy Susana y estoy curada.
Soy José Luis y estoy curado.
Soy Graciela y estoy curada.
Soy Adrián y estoy curado.
Soy Andrés y estoy curado.
Hola, soy Miguel y estoy curado.
Hola, soy Gabriel y estoy curado.
Soy Carlos y estoy curado.
Soy Nelly y estoy curada.
Soy Claudio, estoy curado.
Soy Rubén y estoy curado.
We welcome you. We're live now. We welcome you to this session of the World Hepatitis Summit. These are the first breakout sessions, parallel sessions in the afternoon of day number 1. Thanks a lot for joining us. Our session is called Leave No One Behind, and sorry for starting a little bit late. We're still getting the systems up. It was a great morning with very, very good welcoming ceremony, and we thank you for joining us. We have great speakers on the panel, and I'm very happy to introduce Javier, who is co-chairing the session with me. I'm Niklas Luhmann from the WHO Global Hepatitis Program. I'll introduce Javier after my short introductory remarks. So I think let me just share a very short presentation with you. for this session. And as I said, the session is on leaving no one behind, and the importance of health equity in the viral hepatitis response. The objectives of the session are really that it will explore those issues about health inequality, focusing on viral hepatitis, and share some best practices. Actually, we have quite an amazing lineup of panelists who submitted abstracts, and as well a country speaker from Colombia, Dr. Cielo, who will talk first. And we want to hear from Javier as well some community perspectives on this issue, which is very, very much obviously observed and highlighted always by the communities as well. I mean, it is a very timely summit for many reasons, but one of the reasons being that just only 2 weeks ago, really, the new global health sector strategy had been has been appreciated and approved by the member states of the World Hepatitis Assembly here in Geneva. And this is one of the new frameworks for the global health sector strategy. And as you see, I highlighted in red that beyond the strategic directions, it is really very, very strongly highlighted in the strategy that some of the core drivers of progress are equity, gender, and human rights questions, along with funding, which is as well one of the core issues around the viral hepatitis response and leadership and partnerships. So it's very important in our strategy. I think everybody would know on the call that obviously health inequities are a very important issue, and really the determinants of health can increase vulnerabilities in communities, and this can include, people who face poorer socioeconomic backgrounds, or people who are discriminated based on age, gender, sexual orientations, or other population characteristics such as related to drug use or many others. So we know that from an HIV perspective, some of the populations, including MSM, transgender and gender diverse people, and people who inject drugs, have been called key populations because in addition to facing health inequalities, they face as well really criminalization in some contexts. And so really they are additionally vulnerable and subject to punitive legislation and policing practices. So what to do? I just wanted to go very quickly into this slide, and this comes as well from the new global health sector strategy. First of all, to say that it is actually the WHO mission to serve the vulnerable and leave no one behind. So this is one of the absolutely core high-level missions of WHO overall, not only related to infectious disease or our disease areas. And this will not be achieved when inequalities are not addressed. And this can be many inequalities among countries, in between countries, within countries, but inequalities are really driving some of those epidemics. And to address those inequalities, really, it is community leadership and political commitment, which are the core drivers of a good response. And now the strategy focuses much more on people-centered and rights-based health systems, not so disease-specific, but really focusing on people's needs. And then last but not least, which is very much linked to the other bullet points, is that stigma and discrimination has to be addressed. And actually unfortunately, or it's maybe understandable to some extent, we see stigma and discrimination in the healthcare setting, among the health workforce. And so people need to be trained about this. And really, if we could address stigma and discrimination in the health workforce, that would maybe allow us to make a huge leap forward. So this just comes from the strategy. I'm not going to go through that. I will hand to Javier, but I was just highlighting in blue some of the very vulnerable populations in the hepatitis response. They include everyone who is on the slide and possibly other people, but it is some of the key populations from HIV, but it includes as well migrant populations. We know that in many high-income countries, for example, some of the migrant populations have higher hepatitis B prevalence because of where they come from and the background prevalence in the countries where they come from. We should highlight as well women and girls, adolescents, as we have heard in the opening ceremony, and for example, indigenous people as well in some of the countries and member states that are highly affected. Obviously, this needs to be context specifically addressed and cannot be, those populations vary from context to context. And I'm sure maybe Dr. Cielo will talk about some of those who are the most vulnerable in the Colombian context. That will be interesting to hear. And the abstracts address many of those from a very interesting point of view. So I thank you very much for joining and for this interesting session. And I'll stop sharing and I hand over to Javier, who is the co-chair, who is actually board member of the Global Fund on behalf of the community and affected populations. And he wanted to share as well some welcome remarks with you. Thanks, Javier, for joining us.
Thank you, Nicholas, and thank you for all the speakers and attendance of this session. I think the main message is now that we have the strategy, each and every people, no matter where sector they belong, need to market in the strategy. It needs to increase and spread the news that we have a health sector strategy, which is state of the art. But we also know that to realize the solution proposed by the strategy or reach the targets, the multiple targets, we must scale up country ownership, leading the response on viral hepatitis as well as HIV, TB, malaria, STIs, immunization, etc. And that will not happen by only having a global strategy for those diseases endorsed by member states or Ministry of Health. We will require civil society, community, and key affected and vulnerable populations advocacy and involvement, which is a different concept from community-based health workers. Are two different groups of different constituencies. We also need international and domestic sustainable investment and integrated the response to hepatitis and other diseases into a broader agenda of universal health coverage for all. We already have an emerging, amazing, very vibrant civil society and advocacy movement on hepatitis that was always a gap in the past. So it's important we always keep to reminding that nothing for them without them, not speaking on behalf of them. They have their own voices. And of course, we can compare how HIV or TB community mobilization could help or not, or what are the lessons learned on advocacy, policy, etc. for the hepatitis movement. But there are also uniqueness in each of these diseases, apart from the co-infection that also could strengthen both the movement of people in with HIV, co-infected with hepatitis, etc. But I think that we need now to support each other, people coming from different constituencies and civil society advocates and activists to create demand, to scale up investment, domestic and international, monitor the commitments. So in the next high-level meeting, World Health Assembly or UN General Assembly, we have something to show that we are reaching the targets. Having said that, I have the honor to present someone from my own region, which is Doctora Cielo Janet Rios Hincapié. She's a specialist expert who works both on HIV, STIs, and hepatitis in the Ministry of Health of Colombia. And she will be speaking to us on how Colombia is working to develop an hepatitis response, including the most vulnerable populations. Doctora.
Thank you very much, Javier. And thank you to the World Hepatitis Summit for inviting me to this event. Then just give me a moment, I'm going to project. Okay, then I'm going to mention what we are doing to develop our hepatitis response, including the most vulnerable populations and no conflicts of interest. Our response starts from the integrated planning. We have a national response plan that covers STI, HIV, tuberculosis, HIV co-infection, and hepatitis B and C since 2018. We are about to present the new national plan that would be 2022-2025. And from this plan, then all our activities come out to different groups and to different activities. I'm just projecting in this slide also how from modeling, a modeling that we did in 2019 related with hepatitis B, we managed to see the impact of extending vaccination activities to key populations. And then based on this, we decided to write some orientations for screening and vaccination against hepatitis B to prioritize vulnerable populations. We set priorities because we have 5 main populations benefiting from these vaccination activities. They are men who have sex with men, transgender women, sexual workers, people who inject drugs, and homeless people. We did a pilot in 2017 where we only managed to reach with the third dose 24% of those who received the first doses. But after this modeling, then we decided that it was worthy to try again and then to do again this type of activities. Then aside from that, now we have the vaccines. They only arrived in 2021 due to the COVID pandemic. And then we are just rolling out again the screening vaccination activities for these 5 populations. Second, I want to talk about the EDMI Plus strategy. Remember, PAHO in the Americas region is targeting and have integrated the elimination of HIV, syphilis, hepatitis B, and Chagas disease for pregnant women in our region. Then we adopt the PAHO strategy, and with the strategy, we also develop a toolbox for the health staff to be able to present and then to work with the pregnant women on these 4 events. Then as you can see in this slide, then we have infographics, brochures, flip charts, and other tools to be able to present the pregnant women the importance and the relevance of these 4 diseases. And as you can see also, we have reflected in the work that we did, the indigenous populations, the Black communities, in a way that they can feel all represented when they are seeing the materials and they get involved along the process. Then another activity that we have been doing is tools for health information and education for people who inject drugs. These materials are called Aguanta Cuidarse. That this is there is not an exact translation, but I interpret it as it's worthy to take care of yourself, because very much the Aguanta Cuidarse is a little bit of slang. And then these tools includes also flip charts, questions and answers, and a video on hepatitis C, and also HIV for people who inject drugs. One innovative thing is that these materials are not only focused on HIV, they cover STIs, HIV, hepatitis, HTLV, tuberculosis, Chagas disease, COVID, overdoses, and harm reduction, among other topics that are covered. Of course, we do not talk about everything on the same session, but then it's a process for education, and then we can show different things on each contact that we have with the population. We train 400 professionals on these materials. We managed to get a printed version through the Global Fund. Due to that, luckily we have included the HIV, that it was possible to print it through their funds. And then we are doing follow-up at the regional level. Then these materials have been used by the staff that works at the communities. Then you can see some pictures of the education activities that they do on the streets. And also these activities are done before offering the test to the populations. Also, as you can see in one of the pictures, the video that we did related with hepatitis and HIV is on the Global Fund platform that we have in Colombia for key populations. In a way that they do not only see HIV things, but they also see the integration with other diseases. And also the things that work at the communities also promote other social activities for reincorporation of people that had been homeless or that had been on drugs, like the person that you can see on the slide, that was previously a person who was injecting drugs, then went through different process, and now is working at the restaurant. Also, among those activities for key populations, of course, we have condom distribution, needle and syringes programs, opioid substitution therapies, and they are done at the community level. At the bottom, you see the app that the Global Fund designed during the COVID pandemic to be able to offer the services. There is a small part that it says prevention kit, and then when a person goes into the app and wants to get the condoms or the syringes, then they just click there, they get an appointment, and with this appointment, they go and they get the services. They can also book an appointment for rapid tests. Then this had been an innovation that needed to be implemented during the COVID pandemic, but is extending, of course, after that. It was one of those lessons that we managed to keep going. And then is helping all the key populations to do their own appointments and get tests when they want. We are also integrating testing for syphilis, HIV, hepatitis B, and hepatitis C. Of course, not in the whole country is being implemented. The different local governments may have the 4 tests or not, but the idea is that we should be able to take advantage of all those approaches that we do to the key populations to offer not only an HIV test or hepatitis B test, that just to be able to offer the 4 of them. Then here you have some of the activities that are done with people who inject drugs, sexual workers. And the last slide is important because this activity was not done by the government. It was organized by the Association of Hepatologists in Colombia, and they did it at the Tattoo Fest, promoting the hepatitis C test for those persons who had tattoos. And finally, I want to show how we managed to leverage some of the resources of the Global Fund. They paid for the study of HIV prevalence among people who inject drugs, and through PAHO, we managed to get the test to also do syphilis, hepatitis B, and hepatitis C. Then it was an interaction, and as you can see, the prevalence of antibodies for hepatitis C among the people who inject drugs were so high as 80% in some of the cities, and it was it's already very much an urgent issue that we need to address. We are working with the insurers in our country to be able to make sure that these persons that were detected at the study get into the services, and then that's one task ahead that we have. Finally, we are integrating also testing for syphilis, HIV, hepatitis B and C on the PrEP program that we are designing at this moment in a way that we are able to take advantage that most of the people who look for PrEP they belong to key populations. Then at the same time, not only to offer the HIV prevention and the HIV test to follow up, that we are able to cover all other diseases, and in that way to promote that prevention in a more comprehensive way. Then this is just to acknowledge all the persons that work with our team, with the HIV team, because it's not only HIV, we also have persons from the drugs program, from the Chagas disease program and others, and of course to PAHO, who have been supporting us along all the different activities that we have been doing in the country. Thank you very much.
Thank you very much, Doctora Rios Hincapié, and the experience of Colombia, and something we have been here in the last couple of days, integration, the amazing experience in Colombia of testing and treating people for 4 infections, especially key populations. That's the only way we reach all the targets. And another exemplary country responding to multiple of those diseases is Brazil. And we have today with us Livia Melo Villar from one of the most prestigious institutes in the region, the Instituto Fiocruz de Brazil. She will be speaking about hepatitis A, B, and C, seroprevalence in vulnerable quilombola, sorry for my pronunciation, population in the northeast of Brazil. Livia, the floor is yours.
Thank you so much for this invitation. I will share my presentation to you. Thank you so much. So good morning. I am Dr. Livia Melo Vilar. I am the head of Brazilian Reference Laboratory for Viral Hepatitis at Fiocruz. And now I will present our study, part of one of our studies from our lab that's named Hepatitis A, B, and C seroprevalence in the vulnerable quilombola population from Northeast Brazil. This study is a collaboration study between Fiocruz from Rio de Janeiro and also Fiocruz Piauí. So as background, hepatitis A, B, and C virus are the main responsible for cases of acute and chronic hepatitis all over the world. But during the Brazilian slavery period, many African migrants were brought to the American continent. These individuals usually have to escape from Brazilian gold mines and farms to which they had been brought and settled in the remote valleys, forming communities called quilombos. These are groups with distinct ethnic identity, specific behavior habits, including geographic isolation and conservative practices. So these individuals nowadays are forming the quilombola communities. These are landed in Brazil. We have more than 1,000 land titling process of quilombola lands, as we can see that in this map. But only 186 lands are officially named as quilombola. Brazil is divided in 5 regions, and in the northeast region, there's a state named Piauí, where we have 5 quilombola titled lands. These communities generally have unsatisfactory sanitation, low infrastructure, and access to health, goods, and service. So in this situation, it's important to understand and to recognize the impact of hepatitis virus in these communities.
Dr.
So
Livia, I'm just
of this study,
sorry, I have to. I'm wondering, we don't see your presentation in full presentation mode, but I'm wondering as well if you already moved the slides. We are still on the first slide, on the title slide. So maybe
you are not seeing my presentation, but here is going on.
We see it in non-presentation mode. Which slide are you presenting?
I'm present now the objectives. You are not seeing that?
No.
Yeah,
can you go out and share again?
I will stop the share and try to share
exactly.
Again.
We are sorry to interrupt you, but
no
now,
problem.
yes,
now
and full on. Okay, perfect. Just move for checking. Next slide to see if it moves.
I can see. Do you want to repeat the other?
No. It's fine. Just continue. Thanks.
That's the first slide where I talked about the quilombola communities, the distribution of these communities in the Brazil area. See it, and the northeast region of Brazil with Piauí state. So the objective of this study was to evaluate the seroprevalence of infection by hepatitis A virus, hepatitis B, and hepatitis C in vulnerable quilombola communities located in the state of Piauí, northeast Brazil, to give data that could help to formulate prevention and control policies. Now we can see again the map of Brazil and the northeast region, where we have highlighted here the Piauí state. In the Piauí state, we have about 61 lands that are in the process to be named as quilombola. And there was a municipality named São João of Piauí. That's about 10 hours by car from the capital of this state, where we done this study. This is a cross-sectional observation study that was approved by the Fiocruz Ethical Committee. And we have recruited a total of 271 individuals that were located in Quilombola lands from this municipality. These individuals has blood samples obtained by venipuncture after signing a consent form and completing an epidemiological questionnaire. So these samples were sent to Fiocruz, where we did the enzyme immunoassays for hepatitis B as antigen, anti-HBC, anti-HBs, anti-HAV, and anti-HCV. As a result, we observed that most of the individuals were female. The mean age was 36.9 years, and half of these individuals had up to 9 years of education, and about 37% of individuals have a monthly income up to $178 per month. About hepatitis markers, we observed that anti-HCV was found in 0.4%, what's considered a low prevalence. Hepatitis B, in fact, active infection was not observed. However, previous exposure detected by anti-HBC was observed in 5.9%. Immune to hepatitis B detected by anti-HBs was observed in 35.4% of individuals. And total anti-HAV prevalence, that means previous exposure in most of cases, are observed in 65.3%, and no one was acute infected with hepatitis A. But we also observed in these Quilombola communities, we did this study in 4 communities that were different in the prevalence for hepatitis B and hepatitis A. For hepatitis B, the number of immune individuals were high frequency in the Riacho Negro, where for hepatitis A, the number of individuals with more number of previous exposed was observed in Lagoa do Ribeirão, followed by Saco community. As conclusion, we observed a low prevalence of current infection with hepatitis B and C in this population, probably due to the low exposure to this virus, since most of them did not report common such as drug users, for example. Prevalence of previous infection with hepatitis A was relatively high, confirming that sanitary conditions favor the spread of the virus. Now, most of these individuals were not previously vaccinated for hepatitis A, since this vaccination initiated a couple of years in infants. Low prevalence of anti-HBs was observed, reinforcing the need for immunization campaigns in this group to avoid possible new cases of hepatitis B in this population. Nowadays, hepatitis B vaccine is available for all individuals in the public health system in Brazil. So we conclude that health education programs and better sanitary conditions could diminish the risk for viral hepatitis in these communities. I would like to thank you to the Oswaldo Cruz Foundation and the collaborators from Fiocruz Piauí and Federal Institute of Piauí too. I would also like to thank you to financial support of Brazilian Health Minister Fiocruz, CNPq, and FAPERJ, and here's my email for contacts. Thank you so much.
Thank you, Dr. Villar. I will hand over to my co-chair to introduce the next speaker.
Oh, thank you. I didn't know about this. We are having a long day. Thanks, Javier. Actually, we are still wondering for 2 of the speakers who had submitted abstracts. They don't seem to be online. If they are, please write us in the chat. Speakers from Izmir University in Turkey and from Pakistan. While we're waiting, if they still will join us, it's my pleasure to introduce Achim Kautz from Germany and Achim will speak about hepatitis D and an awareness campaign with the Mongolian community in Germany. Actually, that's fantastic, Achim, because not only is that a population issue, but hepatitis D is another even more neglected disease and not very well known. And I think we hope as well at WHO to highlight it a little bit more in the next years. It leads to quite quicker development of liver disease and potentially liver cancer. So it's a very important issue, and Mongolia is one of the countries, but far from being the only one with a high prevalence. So very interesting talk after two talks from the Americas, a talk from Central Europe. Thanks, Achim. Over to you.
Yes, thank you very much. And I will start to present. So thank you very much to give me the possibility here at the World Hepatitis Summit to present a pilot project for hepatitis delta. And Niklas, as you have said, so hepatitis delta is within the framework under the context of viral hepatitis, indeed a neglected disease. And so our intention was right at the beginning, okay, how we can perhaps start a pilot project in raising awareness in a really small population in this Mongolian group here in Germany. And so to give you some background, it is that around your estimations from the WHO, it's about 50 million people are chronically infected with hepatitis D. And of course, as you have said, so the co-infection with hepatitis delta can lead to severe chronic progression in 70 up to 90% of all cases. And you may wonder why we here in Germany, in one of the low prevalence countries overall in hepatitis delta, are caring for hepatitis delta, because here are risk groups in Germany as populations with a migrant background from countries with a significant prevalence, and they don't have to be forgotten. And of course, it is expected that a large proportion of these vulnerable groups have no or little knowledge about hepatitis delta or the transmission path and the interaction between hepatitis delta and hepatitis B. And important, as we have seen and heard in the beginning today, it is to educate these risk or at-risk groups. We have to do it in a culturally sensitive way and in a respectful manner. And of course, this project was a little bit to find the needle in the haystack. So we have around 6,400 people from Mongolia living here in Germany, and Germany have 80 million. And so this was really our task. Okay, how to find them, how to start awareness and how to make them active. Because we want to increase their awareness and their understanding of hepatitis delta and their risk factors. And this is a hepatitis global prevalence. And as you can see here, Mongolia is one of the highest part of the country, as well here in Romania, with an anti-hepatitis D prevalence among the HBs antigen positive up to 50%. So the primary goal of this campaign is to educate the target group about hepatitis delta, the transmission routes, but also the prevention options. And they should be encouraged to seek for a test and medical care. But another goal, and I'm part of the German elimination committee, is to create a common voice of all relevant players to raise awareness also on hepatitis delta among the political decision makers in the context of our German hepatitis strategy bis 2030. The project plan. Right at the beginning, so we had a very fruitful discussion with the World Hepatitis Alliance and Gilead Sciences. And at that point, I really like to thank Nicola, Carrie, Cassie, and Rebecca. So we have conceptualized the basic. And then, of course, we have analyzed, okay, the Mongolian community in Germany and mapping across cities. And we had been a little bit lucky because in the end we had around 5 cities where we have a condensed population of the Mongolians living in Germany. Then we started to contact this community and we have organized a kick-off round table. And I guess later when we see the results, this was the key success factor of this project. Because we had started then to co-create the awareness material together with the community, and we had a very close relationship built up. And then, of course, we have distributed it via pre-identified social channels by the community and our company as well. And then, of course, in the second phase, so we had the extension of the cooperating partners and supporters and development of the second awareness wave. And then the climax was in the end of the year that we had a public webinar with the support, and this was really great, the official support of the Mongolian embassy in Germany and the official support with the Ministry of Health in Germany, of course, the Mongolian community and different experts. And here are some impressions of our tweets, Facebook channels, and here a leaflet in Mongolian. And we had developed this leaflet in English, German, and Mongolian language to cover all this Mongolian populations in Germany. And let me come to the conclusions and the outcomes of and learnings of this project. And I think so what has been told now over 20 years, and when we had first discussions with supranational organizations, governments, we can only have a great achievement in such projects if we have the acceptance right in the beginning from the community itself. And here it was right in the beginning that we have involved the Mongolian community in this campaign, in the design of the campaign. We have achieved very, very high acceptance. And the other part is, and I think this is what you have mentioned, Niklas, is setting up this campaign as a community-driven project. We were able to increase the awareness of hepatitis delta, and we were successfully to find the needle in the haystack. In the end, we reached up to 80% of our target group. Currently, we do an evaluation of the increased HDV testing and treatment that is ongoing. And the other factor, and this is the third pillar of success doing such projects, is really no stigmatization by co-creation. Right at the beginning, to have the discussions with the affected population is a key success factor. And that, in the end, has led us to generate high-level supporters, so that in the end, we had the support, as I mentioned, with the Mongolian embassy, the official support from Mongolia, and my support, also support of my Ministry of Health here in Germany. And as you know, I'm working very transparent, and of course we like to share these learnings, and so we create now a white paper with all the perspectives of extending the project to other target group or to other countries. And this is really our hope, that with this really tiny, but I think key pilot project in Germany, we were able to show that everyone can care also for hepatitis delta, the neglected disease within the framework of viral hepatitis. So thank you very much. And if you have questions, you know how to reach me.
Thank you very much for your presentation. Him an excellent experience in Germany with a very sensitive population for all of us is migration, people who are in migration or displaced situations. And we still cannot show if two speakers that I will name now are in the session to present. One is Syed Raza from Pakistan and Dr. Kose from Turkey, because we have a participant without name. So if there one of you are in the session, I feel like I'm doing a spiritism. Please, I'm invoking you to introduce yourself, so you have your opportunity to present. If not, I think that before inviting probably the three speakers to give a bit of 1 minute closure, as well as my co-chair, one thing which was stunning for me, coming from also working in other diseases. Oh, there is a question? Yeah. Can you go it for me?
Yes. Sorry.
Sorry.
Yeah.
Thank you.
Okay. We have a question from the room, and is, I think, to Achim. Involving embassies of immigration is a very innovative approach. How easy was it to engage the embassy? So, and Achim, as there is this question, I would add one from my side. Have you thought already who would be other communities that are vulnerable to hepatitis delta in German context that you would maybe like to reach next? Thanks.
Yes, thank you, Niklas. Well, it was right easy because we had the background and the support of the Mongolian embassy right in the beginning, because we had discussed right at the beginning with the Mongolian community, and this community is very close connected to the embassy. And in the end, we have convinced the embassy in getting confirmation that hepatitis delta is a problem for Mongolians all over the world. And so we got support from them. Niklas, I can hear you very loud. Okay, so we had the support there right easy. And it was also that the connection between my Ministry of Health and the support of my Ministry of Health was very helpful to convince the Mongolian embassy. And to the second question, yes, indeed, we are thinking to reach out the project to other, let's say high at risk population groups here in Germany. And the next group we like to care for is the Turkish population. And perhaps in a later stage, then we would like to reach out to the Romanian populations, because that is something all over the world. You have migrants from all over the world, and so you have high at risk populations. And with this concept, and I'm very happy to share this concept, you can target these populations in reaching out for hepatitis delta in all countries. I hope that answers your questions.
Yeah, thank you very much. And I mean, again, one cross-cutting issue in this presentation was focusing the response on a certain population, whatever is a key population or co-infection with HIV or STIs, etc., the Quilombola community or the Mongolian migrants in Germany. And this is very important because those people who we also work on hepatitis or works in countries with access to hepatitis cure now, they create demand. Finding those people who need to be treated, it's a big, huge challenge. We are running out of time, and sorry that for whatever technical reasons, two speakers could not join this session. And I personally want to thank you, the three amazing speakers. As you know, two Latin Americans, but Latin America have a real endemic situation with migration and displaced people, with all the public health challenge. So I think it's very relevant. And I hand over to my co-chair, Niklas, for an announcement and closure.
Thanks, Javier. With some initial challenges, we had a great session. It was very, very interesting. And one other cross-cutting issue that I just want to highlight before the closing is that really the co-creation of the tools, I think from Colombia as well, they showed, I mean, it's really, whatever you do in collaboration with communities, it will then work much, much better in the end when you implement your services or your health education or whatever it is. And I think, yes, nothing about anyone without anyone should be really applied, and it's always shown again, and the Mongolian example shows it as well. So thanks a lot. The housekeeping is that please stay online. There, if you want, there's a symposium on the impact of stigma and discrimination affecting people who live with hepatitis B. And for those in Geneva, for example, in this room, this will be streamed in the main room. So that's the next program point, the last session today. And join us again tomorrow for the other sessions, the plenary or parallel sessions, if you like. And thanks a lot for the speakers. It was a great pleasure to hear from very specific contexts, including very north in Brazil, very, very interesting community as well. Thank you.